We've had just a day full of all-stars, and we're ending with an all-star panel. This is really, the panel's going to focus on exploring the mental health criminal justice landscape. And so we've gotten a lot of information throughout the day. I'm pleased that we have Katie Habert, who is the Deputy Program Director for Behavioral Health with the Council of State Governments Justice Center with us, who will be facilitating this panel. So without further ado, I'm going to turn it over to Katie to get us started.
All right, thank you very much. Good afternoon, everybody. Great to be here. I first just want to thank Director Butler and CJCC for having me today and putting together this day and this panel in particular. Thank the panelists for being here today as well. First, what we're going to do is I'm just going to make a few brief opening comments and then do a little bit of a highlight overview of some of the breakout sessions today and how that applies to our conversation this afternoon. And then we're going to get into a discussion with our panelists here today. So, as the director mentioned, my name is Katie Habert, and I help direct the Stepping Up initiative, which actually the last speaker spoke a little bit about the Stepping Up initiative. I don't know if you all recall the slide that had those 6 questions on it. It's part of what I work on in partnership with the National Association of Counties, as well as the American Psychiatric Association Foundation. Like the focus here today, Stepping Up really focuses on the collaboration between local agencies and systems in order to develop data-driven plans to really reduce the number of people with mental health conditions in local systems. And the emphasis is on collecting data to understand the scope of the challenge, identifying strategies and bringing those to scale, and how we continually track progress. So very similar to the themes that you all have discussed and heard about so far. We really encourage local systems to think about working towards measurable reductions with 4 key measures. Reducing the number of people with behavioral health conditions in jail, which might sound familiar to folks in terms of the prevention aspect. Reducing their length of stay, increasing connections to care. So I know in particular the breakout session I was in, which we'll talk a little bit about soon, talked a lot about increasing those connections to care and how do we make discharge planning and connections to the community more robust and efficient. And the 4th measure, of course, is reducing recidivism. And so these measures really help allow systems to work together across towards some shared goals and some shared outcomes. What we've learned from the initiative so far that I think is helpful to talk about really briefly is that there are many localities across the country that are facing these challenges to pursuing lasting systems change, right? It's not easy work for sure, but it's very worthwhile. One just really quick anecdote that I'll talk about is we've worked in New York City in particular, where the average length of stay for folks was actually decreasing, which was a win. But when you looked at the data more carefully, they actually found that the real number and percentage of folks that had mental health conditions was actually increasing at the same time. So I think it's really important to think through how we use data to understand what's going on in our systems and to target our resources and strategies and policies accordingly. We also know, though, that it's possible to make a lot of progress and that jurisdictions, including folks in this room, in DC in particular, are really tackling the systems change head on and really making some great progress. I think it's helpful to note that we didn't reach this crisis of too many people with mental health conditions in our jails because of the fault of any one system in particular. It's really important to note that the solutions to this are certainly not going to come from any one system and need to be a group and targeted effort amongst many agencies and systems that you see, many of which are up here today. I would like to briefly talk a little bit about the breakout sessions where you all really talked about the challenges that you're facing and some ways to address them. I'll just briefly summarize some of the key themes, and so forgive me if some details are left out. I know that notes were definitely taken in all of those sessions, and they will be summarized for folks and for the CJCC to really help inform some of the work going forward, meeting some of their strategic priorities. So Luis, oh no, I have it. There we go. Okay, great. So in the first breakout session it was on pre-arrest and court-based diversion, there was a lot of discussion about defining the needs and prioritizing services based on risk and need. So really, what are the right services for the right people at the right time? And can we prioritize certain services for certain people? So if there are folks that have more intensive needs, can we focus those intensive services on them and really match accordingly for best results? There was a lot of conversation on diversion as well in terms of prevention and alternatives to incarceration and some efforts that law enforcement in particular can take to help reduce the number of folks that are being arrested and actually booked into jails. Second breakout on implementing effective mental health treatment in jails. Had a lot of discussion about increasing the system-wide warm handoff post-release and back into the community. A lot of discussion on increasing treatment services such as medication-assisted treatment and how we can do that and better make those connections with other agencies as well. And there was certainly a lot of discussion about formalizing information sharing mechanisms. So some discussion about how information is often exchanged between agencies, but oftentimes because of personal relationships. And so thinking through how we can formalize those information sharing mechanisms to really increase that information sharing. And the third breakout was on the impact of trauma and mental illness and systems involvement, And there was some discussion about addressing trauma for people involved in the justice system as well as staff. And I think we've heard that throughout the day as well, how we can take care of folks that are really working in the system as well on these day-to-day. Addressing historical trauma and really what are we doing to break this down, not just sort of what has happened to folks in their lives, but the situations that they find them in as part of historical trauma, and how can we really meaningfully address this across the system and break that down. Increasing community and peer support and improving the continuity of care in reentry services, which might sound familiar from what some of the other breakout sessions discussed as well. I would like to say that it is my understanding that in terms of improving some of this continuity of care and connecting folks to basic reentry services, I believe the CJCC is starting a reentry portal in DC. I'm sorry, correction, but there is a reentry portal in DC that is not up and running yet, but the planning for that is underway, and so might be one of these strategies to help address some of these challenges that folks mentioned in the breakout session as well. And last but certainly not least, community reentry solutions that work. This breakout session really discussed improving coordination from discharge to community and really having a wraparound team approach to help folks navigate the return to the community and what people need to be successful. A need for shared language, between agencies and community-based providers. I think very important to make sure that we're all speaking the same language and are able to communicate effectively about our different strategies and outcomes that we want to see. Having the client be a part of defining what success is. It may be different for each person, how they might define their success in terms of their recovery and reentry back into community. And also reducing stigma, as well as more training for practitioners who work with folks that are involved in the justice system, and so that they can be more effective and people can feel much more heard. So I think it's helpful to synthesize what everyone had spoken about, and I know that there was a lot more conversation as well, but helpful to sort of hear what some of the challenges were, and I would just encourage the panelists to think through how you might be able to address some of these challenges that folks raised in your comments today as we're going through the questions. I will say that, and I promise I'll be brief, I know we want to hear from folks up on the panel. You know, as we address the challenges that you all brought up during these sessions, it's important to think through what does that mean for systems change, and what does that mean in practice when we talk about systems change. I think it really means moving from small pilot programs, which are absolutely useful when we know things work. It's helpful to move from those programs to initiatives that operate at scale to really meet the sufficient need. It means moving from a focus on measuring outputs, such as how many people graduated from a program, to a focus on outcomes, such as are we actually reducing the number of people that are being booked into local systems. I think it's a shift from working in silos to multi-sector collaboration, which we'll be talking a lot today, and certainly a focus on a data-driven approach to really think through how we utilize data to inform our decisions and be able to track progress. I think today's discussion has really been just that, how DC has been doing these things and improving outcomes for people. And as we close out this day together, we're really honored to have these panelists up here to talk through all of the challenges and things that you all mentioned and how these are being addressed on an agency and systems-wide level and what we're doing moving forward to continue to help the folks involved in the justice system. So today we are lucky to have with us, I'll just run through names really quickly, although I'm sure folks in the room are familiar with the people that we have here. We have Kelly O'Meara, who's the Executive Director of the Office of Strategic Change from the Metropolitan Police Department. We have Leslie Cooper, who's the Director of the Pretrial Services Agency. Dr. Tanya Royster, the Director of the Department of Behavioral Health, you all heard from earlier today as well. Ms. Rhonda Tilden, who's the Assistant Chief of the Mental Health Section for the Office of the Attorney General. Ms. Colleen Kennedy, the Assistant U.S. Attorney General at the United States Attorney's Office for the Eastern District of D.C.
No, that's wrong. Assistant U.S. Attorney in D.C. for Washington, D.C.
For Washington, D.C.
Right.
Great, thank you. We have Robert Morin, who's the Chief Judge of the Superior Court and the D.C. Courts. Keisha Gordon, who's the Branch Chief in the Mental Health Unit at CSOSA. Patricia Smoot, who's the Chairwoman of the U.S. Parole Commission. And Councilman Charles Allen of Ward 6, who's the Chairman of the CJCC and is also part of the Committee on Judiciary and Public Safety. So we'll go ahead and get started. We have a wonderful large panel here and a few hours with you all. And so we will make sure to go ahead and get started. And there will also be some time for questions at the end from folks as well. So we're going to start off with Councilman Allen. We know that the factors that drive the disproportionate criminal justice involvement among people with mental health conditions can be traced to a multitude of actors: law enforcement, courts, behavioral health, etc. And likewise, it's going to take a village and a collaborative effort to really pursue systems reforms and change. Yet, it's often hard to get a lot of semi-independent agencies to work together towards a common goal. I'm wondering if you wouldn't mind talking a little bit about the importance of multi-agency collaboration, and in particular, how the CJCC has really worked to build that collaboration and what strategies have been effective.
Well, thank you very much and good afternoon. It's nice to also be in here because at least the council, we call this the old council chambers. As a member of the new council, this is my first time sitting up here, so I feel like I have something to tell Jack Evans and Phil Mendelssohn when I see them here. And as we walked up, my fellow panelists asked me a couple of tips of how to act like a council member up on the dais, so it was very easy. First off, ignore all time limits. Rule number 2 is to talk over one another while you're trying to present. Rule number 3 is to make wild accusations from the dais and the microphone. And then you too can be a council member. So I'm glad that you had me here, and I'm happy to talk. I think I was actually here last year as well when I had just taken over the committee, so I felt like the new kid on the block, and with one more year under my belt, I do not feel like the veteran yet, but I'm really grateful to have so many great partners in this room and around the table to help me do my job. When it comes to how we bring agencies together, to me it kind of breaks in a couple of places. First is kind of the interagency collaboration. So how do you get some of your interagency folks around the table? And sometimes that's a little bit easier. Then there's the multi-agency. So how do you get kind of groups from within a cluster to come around the table? That, to me, is where I think CJCC does really well. When we think about our principals meetings, we all work roughly within the same cluster, and so we're able to come together to think through ideas, talk through ideas, share information. I think CJCC also plays a role where it's not just a convening of the people and the principals, but also starts to be a place where technology and tools are used. So if you think about our justice systems or other ways that CJCC kind of becomes the house and the agencies kind of plug into the entities that are working. And then I think one of our biggest challenges, and this isn't limited to CJCC, this is for all of us, is also how do we find ways to partner with our non-traditional cluster agencies or our non-traditional partners. And I think about one of the groups that I work with closely within CJCC is the Combating Violent Crime Working Group. And we have a really good partnership of entities and offices that come together to help think through how we combat violent crime. And there's a project we've been engaged with for the last year where we're trying to think through how our built environment also helps impact where crime takes place, for example. And so we've actually done a whole lot of great thinking around how this works. David Maramon's been leading us on the data, just doing some really great thinking about how to strategically think through how we make a safe and a just city. Where I kind of start thinking when I look around that table is I feel like we've built up, because we have a lot of the trust now with our federal partners, our local partners, our legislative branch, our executive branch, our courts. But if we're going to help think those through, we also have to think about the non-traditional partners that would actually have to help take whatever the outputs are that we come up with to actually implement change. And that's an area where I hope as we continue to work with CJCC, but also I think as we all work within our own realms, how do we take the work that we do and then be able to expand it beyond the people in the room right here? Because I think to be able to fully effectuate that is going to just take a lot more. When I think on mental health, for example, at the council, we've been starting to have more and more conversations around how do I, as the chair of Judiciary and Public Safety, partner with the Committee on Education to be thinking about how do we work within our school system to help young people on mental health before they touch the criminal justice system? How do I work with the Committee on Workforce and Housing so that we think about mental health in a housing capacity, we think about mental health in a workplace and environment, employment perspective. And so I think we're trying to help think through some of these ways that we interact with that. Because if we only think about mental health from a health and human services perspective, well then there's only one committee on the council who would ever touch that. And that's going to do a disservice. And so I think as all of us in this room, I think are all trying to pull in the same directions as we think about where each of our own respective spaces are. There's a lot of other partners that are sometimes the non-traditional partners that help us bring a true cross-agency perspective to the work that we're trying to accomplish.
So we're going to dive into a little bit of specific questions for those agencies. We're going to start with Ms. O'Meara and talking about arrest as the entry point into the criminal justice system. And there have been a lot of movement in DC and around the country to provide law enforcement officers with options other than arrest in order to divert people with behavioral health conditions from the justice system. And love for you to talk a little bit about what systems, partnerships, and coordination are essential for law enforcement to be able to successfully divert people from the justice system.
Thank you so much for this opportunity to talk a bit about this today. You know, it's funny because over the past couple of years, we've had more and more groups and individuals coming to MPD and saying, why can't you do a pre-arrest diversion program? You know, don't you realize that you can't arrest your way out of this? And we know that at MPD. Our leadership, I've been working at MPD since Chief Ramsey was the chief. And one of my first encounters at the council was with a council member who's no longer there, who had proposed that what the city needed to do to deal with crime issues was hire 1,600 additional police officers, 200 for each ward. So that would have more than doubled the number of officers that we had. And Chief Ramsey very respectfully said, you know, I appreciate that. Certainly we could use a few more officers, but what we really need to do is invest in services and programs to address mental health and substance abuse disorders. And he was absolutely right, as we all know here. But beyond that, what we also need are the tools that make it easier for an officer to implement it. Officers are oriented toward action. It's both sort of their natural bent and their training, they're supposed to do something on the scene. It's also the response that they get from the community. The community calls an officer and they want something done. So my role in the department, strategic change, is to work to help develop the tools that an officer can use, the training, the policy that can help guide them, and to work with our partner agencies to make sure, one of the groups mentioned the warm handoff, to make sure that what we do is productive. So we have a great working group right now. Director Dr. Royster had mentioned it earlier, working on a pre-arrest diversion program. And what we're doing is working through the nitty-gritty of how that handoff will happen. From MPD, an officer encountering someone on the street who, may be committing something that is, or exhibiting behavior that is criminal, but that we can deal with in another way. I would also add to this, beyond what the agencies do together, one of the things that I think collectively this group can also work on is the community expectations. We talked about it during our breakout session a bit, in terms of, my officers, obviously they're strong people. They can take some pressure from the community, but when what they are getting repeatedly over and over from the community is, why aren't you making an arrest? That's not going to help any of us. So we need to both give them the tools, provide the connections with the other agencies, and have a community conversation about how we have alternatives and be able to demonstrate to them the effectiveness of the programs that we're running.
I was wondering, you mentioned this a little bit, but wondering if you can maybe expand upon what improvements you think can be made perhaps in community resources available, or identifying people from calls for service that are appropriate for diversion to facilitate more diversion where appropriate, and maybe some resources that you think would be necessary to do so.
Sure. So we've actually been working, the first step that MPD and the other agencies took about 10 years ago, and the Department of Behavioral Health is our strong partner in this, on our crisis intervention officers. And so that's a program I think most of you are familiar with. And our officers are trained by DBH. We have about 800 officers trained now to respond when there is a crisis and help assist that individual to connect them with services. The gap was, well, what about everybody who is not in crisis? So we do have, Dr. Royster went through just the wealth of opportunities and services available in the city to help this population. What we want our team to be able to do is to get them there without having to arrest them. They shouldn't have to wait till they're before a prosecutor or a judge to get into the system. So I think the resources are there, which is the good news. Although maybe our program will become so successful we'll run out of capacity. But really it's about the connection, which under Dr. Royster, the council, the mayor, and Chief Newsham, we're really moving it forward. So we're looking forward to seeing what happens with it.
So we're going to move to a pre-trial, so Director Cooper. And if it's a sort of worst case scenario, not able to divert someone ending up being arrested, wondering if you could talk a little bit about the importance of having some relevant information about behavioral health needs for defendants, and how that really informs decision making at the pretrial level.
Sure. Again, I'd like to echo my colleagues in saying we appreciate the opportunities to really have this discussion, because we understand that really knowing where that intersection is critical to figuring the way forward. And so we appreciate having the opportunity to participate today. With respect to the question that was asked, risk assessment really is the foundation of what we do within pretrial. Risk assessment informs all of the recommendations that we make to the court regarding release or detention decisions for individuals awaiting trial. And for those persons who are ultimately placed on supervision while pending trial, that risk assessment information is what guides our interventions with people along that pathway. And so for us, having access to that behavioral health information is critical. As a part of our diagnostic interview, we obtain some initial indicators of a person's either prior mental health involvement, or if they have an active diagnosis that they're able to share with us, we obtain that information, and that informs the recommendations that we make to the court. I'd also like to highlight a partnership that we have with the Department of Behavioral Health. If we are interviewing a defendant in the cell block prior to first appearance, and the defendant appears to have a mental health condition that is going to make it very difficult for them to understand the diagnostic process or difficult to comply with the requirements of the pretrial process, we do reach out to our partners at DBH, so I'd like to thank you all for that resource as well. We reach out to our partners at DBH and we do a more in-depth screening for those individuals. Again, because we are very time limited prior to that first appearance, we get that screening information, and that typically results in us requesting a release condition that has to do with further assessment and then appropriate placement when that is what is necessary. So it is absolutely critical for us to have a good initial diagnostic picture so that we know from a pretrial perspective how to structure the release condition recommendations, and then ultimately how to structure the supervision process for those people placed on supervision.
Director Cooper, I'm wondering if you can talk a little bit about, you mentioned the partnership with DBH and maybe how important it is to have these resources available in the community to be able to minimize risks of non-appearance, as well as just general availability of services and how that helps with pretrial release.
Yeah, I think it's a great question. CJCC started off this morning by giving us the Options Finder survey. And one of the questions that was asked was whether or not the criminal justice system has adequate training to address individuals with mental illness. I answer that question yes, because I think we have adequate training. What I don't think we have is adequate resources in order to properly serve all of the needs of individuals that are coming through the criminal justice system. And so it is absolutely critical that members of the criminal justice system collaborate here on the local level with DBH. I think DBH does a wonderful job of making its resources available to us because by and large, pretrials resources are dedicated to that immediate risk containment. And so if you think about risk containment from our perspective as being making sure that people show up to court every time they're required to show up to court and making sure that they do not get rearrested. A key piece of that risk containment or risk mitigation strategy really is addressing those criminogenic needs. And when mental health is in play for those individuals, we have to be able to have timely and appropriate resources to which we can refer individuals to help stabilize them. And so it is of the utmost importance that we have the connections and immediate access to those resources to allow people to receive the stabilization that is necessary to allow them to remain compliant during the pretrial period. And so I cannot underscore enough the significance of the partnerships that are necessary both at the government level and then I think at the community-based level in order to make sure that people are properly resourced. I was really intrigued by a lot of the conversation that was had around Medicaid and Medicaid support, and I think that as a system, we need to kind of collectively look at what such a model might look like if we were to expand it here in DC, because I do know that there's bandwidth and capacity issues at the DBH level, so I don't think that we would be wise to simply say, well, let's send everyone over to DBH and see how that works out. I think that we need to be realistic about capacity limitations and really start to think about a prioritization system that would allow us to tap into DBH for our highest need cases and then look at other options for individuals who may be further out on the continuum of care.
Dr. Royster, your presentation this morning really struck me when you were talking in particular about the overlap sometimes in populations served from different agencies across, and sometimes there's overlap here, sometimes there's overlap here. And you know, we know that in order to help reduce the number of people that have mental health conditions in jails, that we first need to identify who those people are in our systems and have a really robust screening and assessment process. I'm wondering if you can talk a little bit about steps that you've taken to improve that screening and assessment process at the different intercepts in the criminal justice system, and what challenges maybe you've faced in pursuing that kind of universal screening and assessment.
Yes, well, thank you again for that question and for this amazing panel. As we all work together on tons of different committees, but it's rare to get us all in one location at one time for 2 hours. So this is a thrill just to be sitting here. But we are very proud of the work that we're doing at each of the intercepts. Actually, Tanya and Retna, raise your hands. Those are our DOC reentry liaisons. And so they're an example of real people who are in the jail working with, oh yeah, I'm sorry, I see the third one, I'm sorry. Real people who are on the ground doing the work that we're talking about. So these 3 DBH staff work in DOC to work with DOC staff and Unity staff, because Unity is the provider of medical care in the DOC. If they identify a person either who came into the system with a mental health need or they identify a mental health need while they're incarcerated in DOC, while Unity is providing their care and supporting their ability to go back to the community, these staff can work with the community to make sure that they connect the person as well. So I like to call it kind of an inside-outside approach. They're there to support the DOC staff. They're there to support successful linkage back to the community. They're also there to make sure our providers in the community are aware that we have consumers in the jail. If they're new, they will make a new linkage. If they're existing, they will make sure that that linkage is strengthened. They also sometimes deliver groups and other activities, information to support the work in the jail. We have similar staff members who are located in other district agencies, as I mentioned this morning, who do similar things for other populations of residents, and some to prevent them from coming in the criminal justice system, and some who are just coming in from another door. Of course, as Kelly stated, with our Metropolitan Police Department partners, we have many opportunities to help intervene and inform the officers on how to connect people and provide assessments. We're not trying to make the police officers clinicians, but we're trying to make sure that they're aware who they should be considering making a formal referral to. So if they can understand just a few questions, because officers have a lot of responsibility and we want them to get back on the street and fight crime, but we want them to be able to ask a few targeted questions to be able to identify people that they should refer to us or to our system, or at least alert us that they're going to penetrate deeper into the criminal justice system so we can catch them and follow them along the way. So our biggest challenge is just the coordination. You asked the question about information sharing. Everyone knows that healthcare information is governed by federal law. And it's not very easy to get, I don't want to say get around, I'll say coordinate those federal laws. And there's a set of laws for mental health information and a separate set of laws which is more restrictive for substance use disorders information. And so it's oftentimes difficult if someone is in a position where they have been arrested and they may not be feeling the warm and fuzzies, that we could get them to sign a consent form to allow us to talk to people, because they're not in a moment of trust. And they're not in a place where they're like, yeah, I'm gonna let you get access to all of my information. So we try very hard, but we're also looking at what kind of processes could we put in place that would support that information sharing that is complying with the federal laws.
So Ms. Tilden, we are talking here about information sharing and screening and assessment and all that leads into data that we can use to drive decision making. And I know one of the 4 priorities your office has established is data-driven juvenile justice reform. Just wondering if you can talk a little bit about what that means to you all, and in particular the focus on an importance of utilizing data for decision making.
So
I wanted to just correct my title. Aisha Lewis is our Deputy Chief of the Mental Health Section of OAG. I'm a mere trial attorney in the Mental Health Section. I spent my first 5.5 years here in the Office of the Attorney General as a line attorney in the Juvenile section. And during that time, we papered over 3,500 juvenile cases a year. And I would paper a kid's case, And then 6 months later, 9 months later, I paper the same kid's case, and it would typically not only be the same offense, it would be a more serious offense, even though from the inception of the kid being arraigned, I would ask the court to put wraparound services around this kid. I would get the kid mental health evaluations, psychoeducational evaluations. We would get a mandatory going to school, like all of these things, right, designed to make sure that this kid was provided services, even if the case fell through. And even if the person was put on probation, it really did not hinder kids from being rearrested. So we got this fabulous Attorney General in 2015 with vision, and he looked at data-driven juvenile justice reform. And basically, data-driven juvenile justice reform means using data and research to make better prosecutorial decisions that result in improved public safety and better outcomes for youth. The data tells us that the cause of the violent behavior and identifies the most effective interventions. For example, we know that when a low or medium risk youth gets involved in the juvenile justice system, their life outcomes plummet. Research shows that in those kids in the juvenile justice system are more likely to miss school, more likely to become truant, more likely to not graduate high school than a low-risk youth that committed a crime but is diverted from the juvenile justice system. So why are we continuing to put kids in the box? Because ultimately, when you get in that juvenile justice box, then when you get out the back door, you're going to the adult criminal justice system. So why? So Attorney General Karl Racine had the vision to implement training. And he trained the AAGs in the juvenile section to really look at adverse childhood experiences at the level of papering, at the point in time when we're considering pleas to offer, and at the time of disposition for these juvenile cases. We're really asking ourselves, what kind of childhood trauma did that kid experience that caused the behavior to happen so that we can prevent it to happen in the future? So instead of back when I was in juvenile, where we really papered a case based on the charge, the seriousness of the charge, we prosecute now on a case-by-case basis. Because, for example, a robbery is not just a robbery. Is it a robbery snatch? Is it a robbery with force? Is it a kid stealing 50 cents off in a playground situation, just a school bully? Or is it a kid that's threatening someone with a gun, and with violence? And we know that about 80%, again, we look at this data, 80% of the youth who complete the Department of Human Services ACE diversion program do not commit another offense 2 years later. The data also informs our increased use of diversion for low and medium risk young people charged with a crime. So since taking office, Attorney General Racine has increased diversion over 5-fold. Before, the options that I had was basically going to a supervisor and begging them to allow me to offer a kid a consent decree, or just try in some way at the disposition level to try to convince the judge to allow me to just have a unique way of trying to get through to the kid. I would ask the judge to have the kid write an essay about why I should use words instead of violence, why it's harmful to be carrying around a shotgun, and so writing apology letters, making the kid do restitution and community service. But now, we've got fabulous programs. We've got deferred sentencing agreements. We've got the restorative justice program. And we really are using more and more the juvenile behavioral diversion program. These things work. these diversions work. And it's all about the data. The data tells us that why do you continue to do the same thing that isn't working? Let's change how we look at the behavior and how to fix it.
And Ms. Tilden, to you again, as one of DC's prosecuting authorities, how do you all balance this priority of utilizing data-driven decision-making with the concern that many prosecutors have about a case winding up in the newspapers and potentially derailing some of those efforts? If you want to speak a little bit to that.
Really, again, we paper cases based on a case-by-case basis, and prosecutors in general have a dual obligation to both prosecute and to do justice. Juvenile prosecutors have an even more complicated and nuanced duty to also advance the care and rehabilitation of the youngsters in the system, as long as doing so is consistent with public safety. Issues of public safety are paramount. As long as data-driven reform is consistent with public safety, it can be advanced. If a given reform were to come at the expense of public safety, the latter would be the priority.
Ms. Kennedy, I'm wondering if you have any additional thoughts on that in terms of balancing the data-driven reform with just sort of a concern about any public reactions to that.
Yes, I have, oh, sorry. Yes, I have a lot to say about that very shortly, so I wondered if I could go last.
Sure. We'll move to Chief Judge. In the courts, there are many opportunities for people with behavioral health conditions who pose a low risk of failure to appear and or a low risk of recidivism to be diverted from the system. I'm wondering what information is key for the courts to make informed decisions on who gets diverted and who doesn't, and what information is necessary for you to really confidently connect people to resources in the community.
Well, thank you for inviting me here, and I really appreciate the conversation that's going on. I think one of the encouraging things from my perspective is what appears to be a coalescing of a conversation about prejudicial intervention, which I've been talking about for quite a while now. I love my court. I think it's a great court. It's got good judges, caring judges. DC Superior Court is not a therapeutic setting. It's like any court. It's rules-based. It's sanctions-based. If you break the rules, there's a sanction. Mentally ill people do not do well in that system. And that doesn't mean we're not trying to do different things, but we spend a lot of resources, judicial resources, supervision resources, policing resources, on trying to fit mentally ill people into our criminal justice paradigm. And it's unfortunate from my point of view because we're the recipients of your work. In other words, we don't go out and get the cases come to us. So for judges, it's very easy to become very cynical about mental health treatment because, as Dr. Royster was saying, we see that small portion of the population that fell through the cracks or was not getting treatment, and we wonder why. So to me, the conversation has to be prejudicial and thinking about creative ways of keeping people out of the criminal justice system to the extent the prosecutors agree. I know Dr. Royster and others know we spend a lot of time, a lot of resources, a lot of DBH resources trying to make individuals competent in misdemeanor cases. Just think about that. We spend months and hours and days at the hospital and at the jail trying to make people competent in misdemeanor cases. And is that a good use of resources? I know we have prosecuting authorities. I know Attorney General Racine. I see United States Attorney Jesse Liu. They know about this issue. They have different community responsibilities that they have to balance, but we're doing the best we can. I think we're being pretty creative in what we offer. We offer the mental health community court, which I think addresses people's needs. But don't mistake what we're trying to do versus what should be done. To answer your question directly, the court is not involved in who decides what diversion they get. That's solely up to our prosecuting authority. We can bring them to the table, have conversations, talk about eligibility, but this is really an executive discussion. The prejudicial, what diversions are off, this is coordination among our city services and our prosecuting authorities. We're going to adjudicate all the cases who come before us, but it's not, I'm not sure people would be proud when they see the number of mentally ill people come before our court and what they have to do to advance their case through the criminal justice system in terms of becoming competent, understanding what's going on. Let me just note one other thing. This is not just a criminal division issue. Our court deals with mentally ill people in all parts of our court. We have a lot of mentally ill people who are appearing in landlord-tenant and family court, families and domestic violence court, dealing with mentally ill family members. This is sort of an issue the court has to deal with in a lot of different aspects, and criminal justice is just one of them. But I love the conversation about prejudicial intervention, and I hope we are creative in addressing those issues there, because it's about criminal justice is based on escalating sanctions. That's the theory of criminal justice. We'll give you an opportunity. If you don't comply, we'll escalate the sanctions. We all know that mental illness is not linear, that it's fluctuating, and it's difficult to address that type of circumstance in criminal justice. That's not saying we don't have a legitimate reason to bring people into the criminal justice system, but we have to give thought to it. I'm not sure I answered your question, but I gave my speech.
I appreciate you highlighting and particularly emphasizing all of the coordination and work that you hope is going on before folks are actually in your courtroom. So I think that it's a good message for folks. I hope you can see we're sort of moving along the line of questioning according to the sequential intercept model. So we're going to keep going and talk to Ms. Gordon now. There's not a single jurisdiction in the country, I think, that would say that there are enough mental health services available for folks. And many would say that the reason that there are so many people with mental health conditions in the justice system is due to a shortage of services. We know that budgets have been decimated over a number of years. What are the tools that you have to ensure that you're really identifying people that are appropriate for behavioral health services that are on supervision, and sort of what's your sense of capacity to help serve those needs?
Well, good afternoon. Thank you for allowing CSOS to be a part of the panel also. Internally, we, as with pretrial, we start out with a risk assessment, a validated auto screener that kind of tells us what the needs and risk are for an individual. We rely on that to pretty much place the person, depending on their need and their risk at that time, into the various units. With the behavioral health population, we take a holistically look at what they're coming in the door and what they need. We've identified that our collaborations have to be stronger, and it's not just one agency, meaning us or someone else. From that, we start out with an assessment where we want the person to receive timely evaluations, timely connections, whether it's a core service agency or acting, and then moving that person along to ensure that the services are actually addressing what they actually need at that time. We do have some internal, and I say some, internal services that we're able to provide in regards of programming, to be able to tackle some of those things, to provide even more wraparound services for this population. And we understand it's not a one-stop, one-shop. What we have actually been doing to increase our collaborations and collective efforts and approaches with working with the different clients that present to us is we've had informational sessions with the core service agencies coming in. We have actually expanded and have individual staff from the core service agencies co-locate with us, where we can actually meet the client at the office and be able to, them to actually handle and receive, knocking out several things at one time. We're able to address that staffing need, also able to talk about the medication management and what their actual treatment plan looks like for them. We've developed a behavior health with our team's provider mobile team that we're taking a collective and a collaborative approach with going out to the providers, sitting in on the meetings, going out, making ourselves known and what we actually do and how we can work together and strengthen our partnerships.
Dr. Royster, I'm wondering if there's anything you'd want to add to that in terms of the partnership with CSOSA and sort of the capacity to provide some of those services for their clients.
Well, CSOSA, works with us very well. They contract with some of the same providers that DVH certifies and some that they do not. But we are focused, I think, together and independently on making sure that the providers that do provide this service understand what the needs are and individualizing them to each consumer. We are, as I mentioned earlier today, looking at ways to increase that and to meet that need. And as the need continues to grow, I would love to come to this group next year and say, so many consumers transferred to our forensic core service agencies that we had to add 2 more, right? I would love to say that. That means we all did our job. We helped people get to the service that we thought was best for them. So it's a continuing, ongoing struggle and work, and part of it is informing that services are available and where the best option for the best services are, and then directing people to take advantage of them. I think the one piece that we always have to keep in mind is that the court does have more leverage than the traditional mental health system, where in a traditional core service agency, the person may not show up for appointments and we can call them and give them a reminder, but if we know they're involved with CSOSA, there's a better chance of us getting that person to engage in treatment. Because we can say, okay, well, you've signed consent for us to talk to CSOSA, and CSOSA knows that you're supposed to be here, so let's make a good choice together, and we can support people in making those choices.
Chairwoman Smoot, I'm wondering if there's anything you'd want to add to that from the perspective of the U.S. Parole Commission in terms of identifying people who are appropriate for behavioral health services on supervision and how you sort of make those connections in the community.
The only way, first of all, I have to echo what everybody else has said about thanking you so much for having this forum to allow us to discuss our different views. Remembering that the Parole Commission is the releasing authority, so we're akin to the court in that we are not, we're certainly not experts in the behavioral health sciences. So we have to rely upon our judicial partners in order to give us information. So we do get information from CSOSA. CSOSA provides our information for violations and everything that practically everything we get with regard to the offenders before us. So we rely upon that information. We cannot make informed decisions if we do not have information from CSOSA. Equally, the Department of Behavioral Health gives us information about how people are doing. Judges and commissioners certainly cannot make appropriate decisions without that collaboration. This would probably be a good time to talk about our mental health docket, which is because we have to make such important life decisions for offenders who are put in this system. And quite frankly, remember, we're at the end of the system. So Unfortunately, we are not able to do anything about those who are involved in, who have mental health disorders who are already in the system. So when we get them, it is what it is. So our decisions, the decisions we have to make are based upon good information that we have about the offender. When we're looking at whether or not a person should be revoked or not revoked, I mean, again, like the court, it's sanction-based. You have certain rules, you come out of the institution, you have certain rules you're supposed to follow. If you do not follow those rules, there are certain consequences. But because we have some discretion, what we do with the mental health court is determine what success is. How are you abiding by the conditions of your release? Are you able to abide by the conditions of your release? And the only way we are able to make that determination is we have experts from CSOSA or experts from the Department of Behavioral Health to tell us what the capacity is of these individuals so we can make informed decisions. And that's exactly what we do in the mental health docket. Talking about collaborations, none of this can be done in a vacuum. When we're sitting and I preside over these hearings, when we have these hearings, we have somebody from the Department of Behavioral Health at the table. We have mental health professionals from CSOSA at the table. We have the Public Defender Service at the table, as well as core agency providers at the table. Together we can, along with the offender, who is a very important participant. We talked about that before. The offender is able to assist us to tell us, what am I able to do as an offender? I'm doing the best I can. You can't necessarily put somebody in jail if they're doing the best they can. So we need all those partners in the room so we can make a more informed decision and use our discretion wisely.
Ms. Gordon, I'm wondering if there's anything you would like to talk about in terms of establishing common metrics for measuring the success of people with behavioral health disorders on supervision across the agencies that are involved in supervision, and how you work together to revisit some of those for decision making.
So I do agree, I do believe that the data is critical. The data, with being able to look at the data, it allows us to know what's working and what isn't. And how we look at success and the lack of. Also by looking at the different progress with the services and the programs and the resources that is being provided, and not just looking at it overall, but looking within to see steps that have been taken by the client while involved in those different programming and services, and looking at the data to that point, so we can continue to make decisions to say what we need to tweak, what may work better with a particular group, and for us to be able to have those collaborative conversations about that. I do feel that we need to identify and know the strategic goals and what each other are even hold important in measuring, to be able to come to the table collectively and then have that discussion about the top priorities and what all of us should prioritize to make sure that, one, we're measuring things and measuring things that we truly can look at the outcomes and not just looking at it in the bigger picture, but actually going down in and seeing the benefits for each individual case by case. Knowing who's in our programs, who is actually involved in the system, what does that look like, and being able to then have these settings along with the different committees and work groups that we have, and come out of those with tangible items that we can continue to work on.
Let me just add something with that. When you're talking about success, you need to talk about the violent offenders and the low-risk offenders, okay? So when you have conditions set on people who are violent offenders, and we're pretty across the board, you need to do what you're supposed to do because we don't want violent offenders out on the street. However, the cases that we're referring to as a group, I believe it's fair to say, are the low-risk offenders who are in and out of the court system, in and out of on and off supervision, kind of the revolving door that you've always heard. So it's incumbent upon all of us to use our discretion wisely. And when you're talking about compliance and successful completion, well, if I'm looking at somebody suffering from a behavioral health problem, substantial compliance is probably all I'm going to get. And again, that is why we need the collaboration of all these groups so we know what substantial compliance is.
Ms. Kennedy, may I look back to you?
Thank you. Can everybody hear me?
No.
Okay. How about now?
No.
All right, I'm going to use Rhonda's. Okay, how about now?
Yes.
All right. I have been a federal prosecutor prosecuting local crime as well as federal for 38 years. My expertise is mental health. I have prosecuted over 200 cases regarding mental illness as far as insanity, competency, incompetency, diminished capacity, anything that comes up. Now, I do not think that it is just a coincidence that thousands of kids today are marching all over the United States for gun control. 17 students were killed in Florida. 22 small children were slaughtered in Sandy Hook, Connecticut. Every single one of these tragedies was a result of a defendant with mental illness. The defendant in Florida who killed these 17 kids struck down in their youth wrote on his computer that he wanted to go in and kill people in his high school. People knew beforehand that this was going to happen. The teachers, his friends, his family stated that they knew he was mentally ill, they knew there were problems, they didn't know how to get help. How do we reach out to these people? What does a mother do when she knows that her son is mentally ill, needs help, and can be dangerous, but there's no direct threat? The defendant doesn't want to get any help. Nothing is done. Tragedy happens again and again. By the time there is an arrest, evaluations, convictions, commitment, it is way too late. I am retiring. All of you, including doctors, lawyers, judges, parents, must face this. You must address it. You need to start a movement like these young kids who are all over there demonstrating because their friends were slaughtered, because they're afraid of going back into their schools, because they want something done about gun control, and we all here need to want and have something done about mental illness. All of you here, brilliant, involved, committed. Go out. Try to change the laws. Get help for parents, to parents, family, friends of these defendants, schools, teachers, law enforcement. Get people to help. Be guided by these young people. Take it on as adults, not just gun control, which is primary, but also mental health. Thank you.
If I could just say, Ms. Kennedy's appeared before me a number of times. She's generally much more reserved.
He's joking.
You know, I have to say, Colleen makes a very impassioned but a very good point. Because even throughout the spectrum, there are folks who really need some real help. And there is a lot of folks out there that don't know how to get it. Civil commitment is ridiculously hard to get somebody to get into a civil commitment. And I can see that there would be a frustration. There is a frustration. I'm certainly a mother who's prosecuting everything else. So it would really be helpful. These are folks that are already in the system. But even some of the folks in the system, some more outreach perhaps about how to get some of this help. All this help is in this room, all of this brain power is in the room, but to get into more people's living rooms.
And okay, we're all jumping in. I try very hard to stay off my soapbox, but I always have to speak up when there is the misconnection between violence and people with mental illnesses. I do not want this room with the impression that people with mental illnesses are more likely to commit crimes. As a matter of fact, they're more likely to be victims of crimes. And so let's please not confuse the public discourse, which is vitally important and critically necessary, with the conversation we're having about how to get people help, how to change the perception of mental illness in the community, how to increase prevention and early intervention so we don't have young people who end up in schools before they're diagnosed with mental illness or before they have challenges acting out in a way that is destructive to their lives and their peers' lives. But I don't want anyone to leave this room with the perception that people with mental illnesses are violent and dangerous as a group.
Thank you, Dr. Royster. Appreciate the clarification on that. And I think one of the things that has been coming up throughout all of these comments is the prevention aspect and how we actually connect people to services that need them, so that we can really start to prevent folks from getting into the system, and again, just really being connected to the help that they need to help themselves and their families. And so Councilman Allen sort of leads into the next question for you about, the challenges that we're talking about up here, that there's sort of a long list of improvements and ways that we can increase connections to care and build capacity for services. And wondering, DC, like all jurisdictions, certainly has a limit to resources, and not to mention limited bandwidth and capacity. And so how does the CJCC, when you hear all of these different challenges that the panel is bringing up and the challenges that folks today brought up in their breakout sessions, how do you really prioritize what systems improvements and programs are really worth pursuing, and how does potentially how does data play a role in that prioritization?
Yeah. Well, I'll start by saying that yes, DC is like many jurisdictions with limited resources, but DC is also unlike many jurisdictions in so many different ways. Not the least of which, of course, is that we have so many DC residents that are incarcerated at the Federal Bureau of Prisons, where we have so little control and say over programs and services and helping take care of those residents for their successful reentry. And I think, in particular, I hear a lot around the lack of being able to provide the type of quality mental health and behavioral health services that we know that they need. When I sit around the table at CJCC, I don't see CJCC as necessarily writing its own priorities. I think that CJCC tries to create a framework, and then all the partners around kind of bring their own strategic goals to it, and then we try to help figure out where we go from there. Where do we find the collaboration between those partners to then chart some courses forward. And sometimes data does play a really important role in that. One example I can think of, just because it was a big part of what we were focused on last year, had to do with how, from the council's perspective, legislatively, I'm working on how we make reforms to our Youth Rehabilitation Act. Pretty important law that was in 1985 and really hadn't been reformed since then. People might remember about a year ago it was the subject of an entire Washington Post series, but the media only had access to a certain amount of data, which I don't think gave the full and complete picture of what our challenges were. And it was frankly CJCC where, because of the relationships and the trust with all the various entities, could pull together data to help inform my policy decision making that otherwise I wouldn't have been able to do. I don't know if Ellen's in the room, but her and her team just did an incredible job of being able to help us see a more complete and full picture. And then that data then helps inform our policy decisions. But I can tell you 100% certainty, I wouldn't have been able to have that data but for CJCC and then the partnerships and relationships that have been built through that. So I think that that's just one example, but that's where I see certainly the way in which the partnerships around the table help bring together data and information that otherwise you couldn't get. And then my perspective is CJC's role then is then to help take what are the strategic goals and initiatives that the partners bring to the table to then help them realize that. And that to me is just kind of one example.
And then sticking with you, Councilman, curious what the awareness and support for this issue in particular. We've been talking about folks with behavioral health conditions in local systems. What is the awareness and support like among your colleagues on the council? And in addition to that, of the gaps and challenges that you've heard today, are there any that you think are maybe particularly well primed for some sort of legislative action?
Yeah, I think at the council, I think we're doing better than we used to, but we still have a ways to go when it comes to trying to think about how we look at all the different touch points on mental behavioral health. But we are taking action in a few places. And I think what's important is that these intersections are happening not just in kind of your traditional silos. So for example, last spring, one of the things that I did as the new chair of the Judiciary and Public Safety was to help fund $4.5 million for an Access to Justice program focusing on making sure that tenants experiencing evictions would have legal counsel. Now, why is that important? 90% of tenants have no attorney. 90% of landlords do have an attorney. So the outcome shouldn't really surprise us of what happens in eviction proceedings. We also know that of the number of people who are facing eviction, we're going to have a substantial number of people who are also experiencing severe mental or behavioral health. And so by having legal counsel there, one, I think helps ensure a better outcome, helps connect those individuals to better services, and potentially helps them keep their home. But in the event that they are going to lose that home, also it helps them move, though, into a smoother transition rather than the abruptness of the marshal showing up and all your stuff's out on the sidewalk. When we think about education, we know that exclusionary disciplinary processes, policies in our school systems, for example, have a very disproportionate impact on communities of color. And so yesterday, the council, and you may have read about this in the paper, took a very big step in how we reform our suspension and expulsion policies within our schools. I don't think I can think of a good reason why a kindergartner should be suspended. Yet that can happen. And so we're trying to think through ways that we are changing the narrative and changing the way in which we approach that. And in many cases, if you think about elementary school or middle school, that could be that young person who's going to be experiencing mental health and behavioral health. And that's what's actually leading to the behavior that then we have this exclusionary discipline policy that says, I'm going to expel you or suspend you. And then we know what happens after that is once I've kicked a kid out of school, many things happen. In addition to the perception of who that individual is, the stigma that will follow with them for the rest of their school probably, but also their own self-worth and perception, as well as, of course, interruption in education. And it has a name, and we call it the school-to-prison pipeline. And so when that happens, we know that for a portion of that, again, the driver may be mental and behavioral health. And so if we have policies set up that really do harm, and disproportionately so, then we have an obligation legislatively to think through how we change that. And that's an action that we're taking. And that came through our education committee. So when you think about, all right, so when we're trying to do a better job of thinking about the legislative steps that we can take, education is starting to think more about mental and behavioral health. Housing is thinking more about mental health and behavioral health. We're starting, I think, kind of the theme of today's entire summit, is where are these intersections taking place? And we are not perfect. We have not got it all figured out, but I do think the council is taking these steps and getting better at recognizing where those intersections are and then helping think through how we push legislation, how we push budgetary resources, how we work with our agency partners, how do we help hold our agency partners accountable, how do we get involved and get engaged to try to push on a wide variety of fronts. And again, don't get trapped in these silos of the only place where we can think about mental and behavioral health is going to be with Dr. Royster and DBH. It takes so much more than that to be successful. And I think that's where the council is evolving and getting to that space.
So we're going to move into a few questions for all of the panelists, should you want to participate. First is a two-part question, just about if there are any promising strategies that you either didn't get a chance to mention or would like to expand upon regarding how you're making progress towards systems improvements. And the second part of that is, what would you need to bring those efforts to scale? Ms. O'Meara, I don't know if we want to go ahead and start with you for that.
Sure. Well, it's a little difficult. It's a little difficult for us to know right now what's going to be needed to bring our new project to scale. We're kicking it off in April. One of the things that I'm particularly pleased about is, I think probably most of you are familiar with the lab at DC, a group of social scientists who are going to help us evaluating the program, fine-tuning it, and then that will also, I think, help us determine, one, its success, and two, what the next step should be. What will we need to do to expand it to make sure, we are reaching all of those who have the need.
Councilman, anything that you'd want to add to that?
The table.
Yes.
I can say I am both hopeful and anxious for the pre-arrest diversion, and part of my role is going to be both from an oversight perspective, working with our partners at MPD, the Deputy Mayor's Office, DVH, of how it's successfully implemented. I'm also, at the same time, going to want to be aggressive and saying, I want to get this rolling as fast as possible. At the same time, I'm going to have an anxiety around capacity, kind of the same way that Ms. O'Meara talked about it. How do I know that as we push hard to take the right steps, that we also have built out the capacity to be able to actually accomplish what we want? Because we don't want to, I don't want it to fail. It is not in anyone's interest for it to fail. So how do I help make sure and push and pull to make sure that we have the capacity we need, the resources are there, so that when we believe that we are taking this very positive step, this innovative step that we want to do, that it's going to be successful. And so that I am going to probably spend a fair amount of time working with our partners from the council's perspective on that one element, because I think it's that critically important to get done and get done right.
Director Cooper?
I think what I'd say in terms of promising strategies that I think will have some system impact is pretrial is at the front end of the system, and we really are a repository of a lot of that initial diagnostic information. And so what we're trying to do is we're trying to leverage that role to be now distributors to the extent allowable of the information that we collect at those front end stages. Again, we have the partnership during the initial lockup with DVH, which is great because it allows us to do some case planning. And what we've very recently done is we've entered into a partnership with the Department of Corrections. So when we identify an individual during the pretrial diagnostic process that has a behavioral health issue, we flag those cases. So for those individuals who are held without bond pending trial, the Department of Corrections does not have to start from ground zero in order to identify and figure out how to begin to intervene. And so what we're doing is we're flagging them, really just in hopes that their diagnostic staff will then be able to pick up on that information and immediately intervene when that is what is necessary, specifically as it relates to people who may have suicidal ideations. And so we're really trying to make sure that to the extent possible we put them on notice of people who may have that issue. I think the second piece is really around collaboration on post-adjudication efforts. And so the vast majority of individuals post-adjudication, if they do not go through the BOP, they'll end up with CSOSA. And so we're continuously looking at ways to improve that information exchange so that CSOSA, like the Department of Corrections, can really pick up and continue the journey with an individual who has already been diagnosed and for whom some diagnostic picture has already been assembled. It's our hope that CSOSA can pick up on that information and continue their interventions based on some of that initial information.
So I did name some of the initiatives that CSOSA is currently working on, specifically with the behavioral health branches. I would like to also add our collaboration with strategy with the Mental Health Community Court and starting that the felony probation program, which started in September 2017. And just the opportunity for us to work collectively with the Mental Health Community Court and being able to refer cases to be certified over that fit a certain criteria and have a identified felony at that time. And just the wraparound services and the increased court interaction that we have with that. And CSOF's identifying 2 specific officers that handle those particular cases. Also, in regards of what Director Cooper just spoke about and our continued work and collaboration with the reentry process, and CSOSA being a part of that, and identifying those cases that are flagged through BOP that have that high need, high risk, and that severe persistent mental illness, along with we're recognizing a lot of medical concerns for individuals that are being released and coming back in addition. So us just continue to strengthen those particular initiatives and moving forward in those. In regards of things that would possibly be needed, one of the core focuses with CSOSA is looking at those 4 top criminogenic risk needs, that antisocial peer, attitude, behavior, and when we talk about the different sessions and what I've heard throughout the day is about speaking the same language, you know, us we're doing a refresher on evidence-based, our refresher on evidence-based practices. So just us as a collective group, making sure that in regards of training, that we're all speaking the same language and know what practices the other agencies are currently using. And lastly, to just continue to move forward, CSOS is currently going through a reorganization. We completed the first phase March 4th, 2018. So it's actually streamlining our processes from a supervision and treatment aspect, and just being able to holistically work collectively to better together, even internally.
So I want to highlight a couple of opportunities that are at the early end of the spectrum to really divert, like true diversion. And so one, I'll start with repeating our CIO officer program, and we talked specifically about the collaboration with MPD, but I'm sure many of you are aware there are many, many more police departments in the District of Columbia other than MPD. And so even though they are, I think, the largest, if I'm not mistaken, just training MPD officers isn't going to solve the problem. So we have also trained police departments from some of the universities, because if you think about it, many times a first mental illness occurs in the college age range. And if those officers aren't aware of how to interact and engage with young people, that could be catastrophic to a person's career development life at a very critical juncture in their life. We've also trained Amtrak police officers, school resource officers, Capitol police officers from the Senate and House of Representatives, and we've had requests for the White House, CIA, DOC. We get lots of requests, so we're working with those agencies to help fund their request because we believe all officers could benefit from this training, not just MPD officers. But even further upstream from that, we're working with our school partners. We know that one of the challenges, I mean, we talked about young people are bullied, and then that causes emotional damage and trauma, and that can lead to behavioral issues. So we're working with the schools about how do we bring more early intervention and prevention services into the schools so that we don't develop adults who have these problems and commit crimes and end up in these situations. So we're trying to intervene at every opportunity and expand the services that are available in every setting that makes sense. And we're constantly, you know, bringing in resources, federal and local, to accomplish those goals.
Chief Judge.
Thank you. As I indicated before, dealing with mentally ill people is not limited to the criminal division. We have, all our divisions are dealing with self-represented people, many of them with mental illness. So we're looking at court-wide strategies to navigate, and we're actually, Dr. Bailey's here under our strategic planning office, looking at developing a navigator program where we can assist people working their way through the court system regardless of what division it is. And in the criminal division, it's been mentioned before, we do have the mental health community court that we work with Department of Behavioral Health and pretrial services, where the prosecuting authorities decide to divert cases into that court where they receive connections to services. It's monitored, people are drug tested, and once they're connected to services, their cases are resolved. We just say we have a lot of judicial capacity that is unused in that court, but we're dependent upon prosecuting authorities deciding what cases should go to that court. So we're engaging in constant communications with our partners who appear before us as prosecutors, asking them to consider cases that might be eligible, that historically have not been viewed as eligible, maybe take a look at this and hopefully intervene in people's lives and redirect them.
So, Judge, I sort of take that as a challenge a little bit.
No,
not at all. Just an invitation. I'm not as involved in the diversion point, but I would say that our civil commitment statute should be looked at again. Our office looks at that as a fairly liberal statute, and that an individual who's been found incompetent and unlikely to regain based on a criminal crime and who is getting through the hurdle of presenting your case before the Mental Health Commission, where it may end, that the commitments are only for 1 year if it's recommended as an inpatient or as an outpatient. Now, it is up to the OAG to refile a petition if they believe that's appropriate, which I understand happens quite frequently. But a 1-year commitment, if it's not repetitioned, is not a great amount of time, especially if the defendant on his own decides to not follow through voluntarily on anything in the community. And again, Dr. Royster, this is just regarding criminals that I've come across in my business, not with individuals out in the community, of which I know many who have mental health issues. So that's all I have to say.
Hi. So there are really two mechanisms for civil commitment for adults with mental illnesses. One is an episode occurs, there is behavior. Let's say there's a simple assault that occurs. Either an officer with arrest powers is called, 911 is called, the officer comes to the scene and assesses the individual, interviews the victim and witnesses, and makes an on-the-street decision at that point. Do I arrest? Or do I discern that this person is exhibiting signs that he or she has a mental illness? Oh, well, maybe I should take this person to CPAP. Let me do an FD-12. So the office of the mental health section of the Office of the Attorney General works very hard with training the police forces in the city in order to make more holistic decisions when they encounter mentally ill persons who have done something minor. Again, we're not talking about the murderers here. A minor offense which suggests that their mental illness is what led to the behavior. And if we mandate mental health treatment, we can prevent the reoccurrence of that behavior, and that is a way to keep the community safe. And so that is the typical, I would say 85% of the mental health cases that I deal with are initiated by the preparation of an FD-12, either by a police officer or an officer agent from the Department of Behavioral Health. Those clinicians know very well how to assess whether a person's mental illness has rendered them likely to injure themselves or others. And it's a great civil commitment system. One issue is it doesn't cover juveniles. So now there is an initiative now for us to, if a juvenile is charged with an offense and a Jackson finding has been entered by the court, in other words, the person's unable to stand trial because they're not competent to stand trial and they are not likely to regain that competency, then now we've started to, we've collaborated, the Department of Behavioral Health has collaborated with the Juvenile section to look at a way for that juvenile to be assessed within a 30-day period to see if civil commitment might be appropriate. And so the Department of Behavioral Health is contracting with clinicians who are able to assess juveniles to see if they might benefit from a mandated civil commitment process. So that is one initiative that is starting. Colleen spoke so passionately about the school shootings that have occurred, and I want to do some justice to one of the initiatives that Carl Racine has started in the juvenile section. It is the restorative justice program. What this program does, it brings the victim and the respondent together to give the victim a voice, control over the process, healing and closure, and helps build the respondent's empathy, consequential thinking, and studies show that it reduces recidivism. Basically, if the victim agrees, instead of prosecuting a case, what we do is we put these folks in a room, right? The victim of a crime and their parents. The respondent who was arrested and his parents. Maybe a coach, maybe someone in the person's life. And these conferences are held at a library, a church, a rec center. And we have facilitators in the Office of the Attorney General, fabulous people. Amin Beal, LaShonia Thompson, are you in the house? There we go. Okay, they are so much more articulate about this program. But can I just say, this is a fabulous program. You get folks in a room, and the facilitator asks questions. And through the asking of questions, folks can have empathy. And the victims can really say, why did you pick me? Why did you do this? And the victim sees that it's a person with issues, and the mother of the respondent can identify this is what's been going on in the house. And this is why my son did this or my daughter did this. And the victim can feel like they have seen justice. Many of these bullied children feel so unempowered and so victimized that they then feel like they need to carry a gun to protect themselves. And then bad choices happen, right? When we get angry and we have access to guns. And these children, this program is just an example of how to fix the problem, because we have an underlying problem there. And this program is expanding to the U.S. Attorney's Office. We've now identified that this program can be duplicated for 18 to 24-year-olds, the Restorative Justice Program. But this is one mechanism to try to look at ways to think outside the box, instead of just throwing people in jail. Because otherwise, how can you really convey to the respondent, you know, you really hurt someone here. And it could have been your sister, it could have been your mama. And if you have a good judge that treats you like they're your, you know, it's their child in front of them, then it's great. It's great, but if you don't have a good prosecutor that takes the time and just expresses in open court, you know, and allows a victim impact statement to be read, then we have to think of other ways to fix the system.
I already actually spoke about our program with regard to mental health, but I will emphasize again that information is power, and informed decision making is what we do at the Parole Commission. So the two things that I would stress, I know that there was conversation about evidence-based practices and training for the staff of CSOSA. I would actually like to see that replicated in the U.S. Attorney's Office, former life, in the Parole Commission, because as we go through that continuum in our process, I think people need to be sensitized to these issues. Not everybody is eligible for the mental health docket, yet at every facet of our job, there are people impacted with mental health issues. So getting that evidence-based information to the staff would be helpful and inform our decision making. The other thing is also talking about information. We are, and everybody's probably heard about it now, our new IT system, management system, and that would allow, once we perfect that, that would allow us to get even more information. We could do some more tracking, and there could be some more data tracking with regard to what works and doesn't work, so that we can prioritize our resources.
Great, so we're almost at time for some audience questions. I just want to ask my final question, and folks kind of went into this during this last round, so I'll leave this open to if anyone wants to add anything about what sort of one thing that you'll do that's either new or continue to do that you found really emphasized through the conversation and discussion today that you'll sort of leave this summit to do to support the reduction of people with behavioral health disorders in the justice system. So curious if anyone wants to sort of jump in on something new that you'll do or something that was emphasized that you'll really continue to work towards.
Well, I will start over here. I think that, you know, I'm very excited about the program we've been talking about today with the pre-arrest diversion, but I think there's also more opportunities for informally giving officers information about the additional resources in the field. You know, even if we don't have a program, there's opportunities to direct people that they find and that they work with to appropriate resources. It's not a measurable program. We don't know what the outcomes will be, but any opportunity to make those connections, I think, can help, you know, serve our public, the people we're all trying to serve. So.
I think one of the things that's not new, but something I'll continue to try to work on and try to think through from my side is diversion, not just from the pre-arrest diversion, but also court diversion. I think Judge Moore is an absolutely wonderful human being, a wonderful person. I'd like for as few people as possible to meet him in his professional capacity. And so if we can think through more ways to strengthen those diversions, I think that would be great.
For the pretrial side, I think coming out of here, I think there are probably three quick things that I'll talk about. Number one, we're going to continue our support of what I think is a fabulous partnership in our mental health community court, which is our primary diversion option for individuals with mental illness. And so we'll continue to support that. I think the second piece is that we are actively undergoing an evaluation of our psychological services that we provide in-house with a specific eye towards ensuring that we have fidelity to the model that we use for trauma-informed care. And so to the extent that that evaluation shows us that we need to do things differently, we look forward to implementing any changes to our protocols that will result from that. And I think the last thing is that we will continue to evaluate our screening and assessment protocols to make sure that we're using the newest state-of-the-science tools that will allow us to get data that will be helpful at all points of the system.
For CSOSA, I think with just continuing to strengthen and increase what we're currently doing in regards of initiatives and our collaborations. Also, we're taking the message back and about each individual's actions and responsiveness to the topics that we're discussing. Again, we've made it clear it's not one person or one agency's job, it's all of us together. And, you know, that being a key factor with correlating the services and just making sure things are done more timely.
I'm looking forward to receiving all of your requests for engagement and trainings and support now that you've had kind of the tip of the iceberg about the things that are possible with engaging with DBH and getting the people that you work with the services and supports they need. We are going to do a better job at communicating with you and making sure that you know how to access these services so that the residents of the District of Columbia can be served.
We're trying to be more practical. I know Judges McKenna and Judge Lee, the presiding judges of the criminal division, have set a meeting for Monday with all our stakeholders to follow up on these discussions and talk about expansion of diversion programs for mentally ill people with low-level cases. So, see you on Monday.
We don't have anything.
Well, I know we're going to get into questions, but first, if you could join me in thanking the panel for their and I think we have a few minutes for questions if folks have any for the panel.
Thank you for an excellent panel. I had a question, and any of the panelists can address it if you'd like. I haven't heard any discussion today about the issue of stigma around seeking and accepting services. On one hand, we've talked about how there should be more services available, but we know that DVH doesn't have waiting lists and can accept more referrals. So there is this problem of how do we motivate people to seek and accept services when we know the need is so great?
Yeah, thank you for asking that question. I'll certainly start with that one because that falls under, I would say, our public awareness. And at any given time, DVH has multiple campaigns about different parts of the system, but we are looking at either taking advantage of some of the national campaigns and tailoring it to the district or creating a new one to continue to address the issue of stigma. We know that all across America, and certainly in different cultures and in certain ethnic and racial populations, there's still stigma about mental health issues, and people would rather go to jail. They would rather be incarcerated than admit that they have a mental illness. And I think that that's part of the reason that there are so many people there who need our services and supports. So it is a continuing conversation and dialogue that I think as a nation and as a city we have to continue to engage in, and part of our job is public awareness. That's also why I'm such a strong believer in the peer movement, because if you can see a person like you saw Anthony stand up this morning, and if you had a conversation with him, if he hadn't have told you his background, you would not have said he was a person with a mental illness. You would not have said he was a person that struggled with addictions. And so the more we have people who have lived that experience and are on the recovery side of their journey be a part of the public face of mental illness, the more we can diminish and reduce stigma.
If I could just add that reluctance to inside our jails and prisons as well. It's a real struggle sometimes to accept services that are available.
Any additional? Looks like we have another question up front.
I think I can talk loud enough. I think, but my name is Redmond Burton, I work for DVH. One of the things I have not, and I've been around, even though I've been around for a little while. Gender-specific treatment. We don't have that. Really upset me. Got a lot of programs over at the jail for men. Nothing quite traumatized women. I was doing a group one day, and this woman told me, my child is my brother. And the young lady, Reggie, talking about trauma, the helper being traumatized, I can remember that. My child is my brother. And I said, wow, how can I respond to that? Normally I'm not a loss for words, but that day I was. So we really need to dedicate more resources to the women who are the mothers, who is the lifeline of our community. And that has not been done.
Yes, yes.
Are there any responses from the panel about increasing those services or opportunities that might be out there for gender-specific services? I'm not sure if Dr. Royster, you'd want to begin?
No, I mean, of course I agree wholeheartedly. You would be surprised, or maybe you wouldn't be surprised, but it is hard because women are oftentimes the bedrock of their families, and they put their own self-care at the bottom of the list. And so women will often suffer in silence. And we have had, even recently, a program that specializes among a couple of providers, but one program that specializes in women with addiction who have young children, and they could bring the young children to residential treatment and live there while they receive their treatment, get child care for the babies up to the age of 10. The children could be, they could bring up to 2 children for each mother. And the program had trouble keeping the beds filled because, you know, we would all say, we know there's a need for that. I know we've all seen it. But it's hard for a woman to leave her community because she's not only taking care of her children, she's usually taking care of her parents and the neighbors and maybe somebody's dog. And so it's often very, very hard. And that's, we have to figure out a way to help women be able and available to take care of themselves so they can continue to do the job they're doing for our communities.
And then, this is a question about the crisis intervention training. We talked a bit about that. There are, and the training is also occurring with other partners, law enforcement partners across the city. I'm thinking about the Office of Unified Communications, which is at the front door in a lot of respects. Can you just speak about opportunities there to really expand the options and opportunities for our community to be trained at each point along the continuum?
Yeah, thank you. We actually have had some very, very preliminary conversations with Director Holmes at OUC. Of course, the 311 and 911 operators have lots of training because they take these calls, but these are such sensitive and challenging issues to deal with that we've talked about how we can continue to support that agency to do its job, and also the secondary trauma. Because if you imagine that you listen to these calls day in and day out, and then you have to go home and deal with your own life. And sometimes the two are very blurred, and it's difficult to separate that. So we absolutely are looking at how do we expand that for government partners, including OUC, and as I said, other partners across the district. We have a lot of different entities in the district who interact with our public. And some of them we are partners with, and some of them we are sisters with. But we have to figure out how to make sure everyone has a thing. It really falls under that larger rubric of trauma-informed city, right? And there have been some tiny, tiny steps toward that. And I think we just have to keep pushing forward.
I'll add briefly on that as well. That I think Director Holmes, she's come in. Our OUC is not always run as well as we want it to, and I think actually Director Holmes is helping right that ship in a good way. So to some degree, it's going to be as she continues to build capacity at OUC. I think we can start to see our call takers start to be able to take on more and more and more in terms of training. There are two things that try to work on that. You know, there are people who call 911 a couple of times a day. And so we have a program partnering with Fire and EMS where we have people that actually go out and try to work on and work with individuals who are abusing our 911 system, but they're abusing it because there is an underlying reason. And so how do we work on getting those individuals to service rather than, you know, saying, Ms. Smith, why are you calling again? And really trying to figure out what's going on. And so that's something that needs to, I think, continue to get beefed up. And then the second part is that we are also going to be rolling out later this spring the nurse triage line with our 911 center. And this is again a partnership with Fire and EMS where individuals that call in, that could be a low acuity call, rather than let's send everybody lights and sirens running to you, let's have a nurse talk to you first. And that can start to have a much more trauma-informed response and start helping figure out what are some of those causes underlying. And in some cases, there's absolutely need to go towards urgent care, emergent care, maybe scheduling with primary care doc the next day, or maybe it's something else. And so I think we're starting to build a system that can be much more responsive and adaptive to what it is that our residents are seeking when they dial 911.
I'd like to also go back to the question just before about services directed towards women, is I think that's absolutely vital. And I also want to talk about the challenge for all of us that we need to rise to is deal with a lot of intersectionality of issues. In addition to other roles, I oversee the department's special liaison branch, and that serves our historically underserved communities from our Asian, African, Latino communities, our LGBT communities, our deaf and hard of hearing communities, and that's only the tip of the iceberg. So for instance, a lot of our immigrant communities are coming from countries where they have been dealing with torture and things like that. So there's one subset. Our transgender population here in the district, a vibrant, vital part of our city, and they can face some special issues. We've already heard and talked a little bit about our deaf and hard of hearing population, and so we need to deal with sort of all of those issues. The stigma issue can be particularly high with some of our immigrants who have come in. So in their home countries, they may not have had any discussion about mental health issues. And so collectively, I don't have any answers. It's a challenge to all of us to keep that in mind as well. We're moving forward on one level, and we need to make sure that we are moving forward collectively for all of these members of our community.
I think we have time for one last question.
Well, I'll be your last question. My name is Kendra. I work with the Corrections Information Council, and I know we talked a lot about resources and the women. I'll take it back to women and services, but I'm wondering if there's a way that we could better use the services that we have and the resources that we have. For example, I know the Fairview Halfway House, they have a capacity of like 60 beds, and they say they have a contract with DOC to have 25 beds, and their census has generally been low. And I'm just wondering if we could do better at maybe trying to link people to the open beds that are available, and see what other things that we already have available in the city.
Anyone like to answer that? Part of the collaborative conversation and process. I think you've given folks a lot to think about in terms of how we can work together to kind of address some of those gaps and challenges.
We can actually take that back as well to continue that.
I think that was it. If you all wouldn't mind joining me again and thanking our wonderful panelists.
So I'm going to close this out with a couple of items. The first is, again, thank you to this panel and to all of the participants. You guys have brought us through the day. You stuck with us all day, so give yourselves a round of applause. I also want to note that the CJCC has a substance abuse treatment mental health services integration task force that again is co-chaired by Dr. Royster and Chairperson Smoot. And so the goal, and we have a cross-section of partners come together to address a host of the issues, a number of which were discussed today. We invite you to be a part of that, and it's not just about the meetings. I'm very much interested in the work. I shared with some colleagues that I enjoy the opportunity to bring these summits to life, but I'm actually very interested in the actions that follow. And so to that end, I want to note a couple of things. First, the CJCC, as was noted earlier, I think Reggie referenced this, the district is a data-driven justice jurisdiction. We have been engaged in partnership with the Office of Unified Communications, the Metropolitan Police Department, the Department of Behavioral Health, Fire and Emergency Management Services, and DC's Healthcare Finance Department to start with, to look at a cohort of individuals to really start getting in front of those who are, as we hear, or they're termed, high utilizers of the system. And the ability to identify individuals with this way will hopefully, from our vantage point, lead to identifying interventions that we can then leverage and apply. The goal is to, we've been working on developing or actually entering into an agreement over the last year. We are near final, near the kind of final stages of that agreement, and look forward to the data collection and analysis process so that we can then provide information to our stakeholders to really focus on interventions. That is underway, and I'm really excited about that work. That work will also then inform efforts that will allow us to partner with a number of other partners that really need to be a part of this type of effort. DC is data-driven. in a lot of respects. I am interested and really will, CJCC is committed to continuing to be a partner in that work that we are engaged in the district, but also being data-driven that leads to policy and practice and implementation that makes sense for us in the District of Columbia. We've had a lot of information shared. I think some of the value of these types of convenings is for folks to look and touch and feel one another and hear firsthand information that may be packaged and available but not necessarily accessible in ways, or that we're not accessing them in ways that may be beneficial. Our charge, and I'm also hoping that you receive you are also deputized to go and share the information that you learned and received today, because if it just stays in this room, it's of no benefit, to be quite frank. We really want to make sure that we're sharing the information so that to that end, all of the slides you'll receive. We ask you to share that. As I noted, we're videotaping these sessions so that we can include them on our websites. We welcome sharing them with you so that you can do the same as you deem appropriate, because the goal is to make sure that we are positively impacting those in the District of Columbia, those that interface with our justice system, and to be quite frank, we are narrowing the funnel. Those who should not be entering the justice system, but really they're off-ramps, we want to create those off-ramps. So these types of sessions allow us to, get closer to that reality. At the beginning, I acknowledged the staff, the team that was really behind this. I acknowledged Khalil, but let me acknowledge Khalil again for all of his work in bringing us together. Luis Diaz, again, in the program development. And actually, all of the CJCC, if you're not standing, please stand. They're kind of lining the room back here. To be quite frank, they are the engine. They're the ones that make this happen and make it look really so seamless. We noticed, we had this inside joke that we could do some event planning because we do this, and it make it look really pretty seamless. So I really just wanted to acknowledge and thank the team for all of their hard work that resulted in what we experienced today. Did you get a lot from today? Yes. Okay. I want to note, for those who are seeking CEU credits, please remember to sign out. You also need to complete your evaluations, but I'm asking everyone, seeking CEU credits or not, to complete the evaluations, because we will be in the throes of thinking about the next summit, and we really want to have the benefit of your thoughts, your insights, and your feedback. Thank you for participating, and we have work to do, so let's continue to roll up our sleeves and get it done.